we've heard all about the problems with having a severe mental illness. If you have a severe mental illness, you will die younger, and that's that. And it is mainly due to cardiovascular and respiratory disease. And there is a significant contribution of lifestyle factors. For the last 15 years or so, I've been very hung up about antipsychotics and the impact of antipsychotics and the impact of lifestyle factors, etc. The one thing, the elephant in the room for me, has really been smoking. And that's because it's actually just too hard to do. Everybody knows how hard it is to give up smoking, but it is one of the main contributors to the physical ill health in our patients. 75%, I would say, plus of people with schizophrenia smoke, compared to 21% of the general public. And in the general public, smoking rates are reducing. Not so in our client group. There was, I don't know if you remember, but there's always this idea that if the people stop smoking, then they'll get more ill. And there's this whole thing about, well, people are smoking to self-medicate against the side effects of the medication we give them. And there are all these kind of ideas around, none of which are properly formulated. But we know that if you stop smoking, it not only helps people clinically, it's also cost-effective. So we work in South London with the NHS Trust, NHS Foundation Trust, sorry, got to say that. And we work in the behavioural developmental disorders CAG. That means that we look after people who have the forensic issues, and we also look after people who have behavioural disorders like autism spectrum disorders, and also the learning disability side of things. And we decided, and I have to say there was so much discussion about this, there was so much deliberation. We were talking about it for a long time, and Mary, sitting over there, is someone in the yes camp. Mary was firmly, always, absolutely, no doubt at all, smoking should be stopped. As I said, I was in the more kind of ambivalent camp. And you can imagine that everybody around the trust, in particular the trust board, were really, in fact actually the trust board were probably the most ambivalent. And so we've been talking about this thing for quite a long time. Our unit happens to be, our units, there's more than one, happens to be inpatient, this is the inpatient side of things rather than community, we run community services too. The inpatient units include the forensic medium secure unit, the behavioural disorders units, which are inpatient settings, lots of inpatient settings, and the neurodevelopmental service units, which are also lots of inpatient settings. And in total, there are about 188 patients, ranging from people in a low secure setting to people in a medium secure setting. And with different types of client groups, so I run the forensic intensive care unit. That's people who really are extremely unwell. If we can't manage you in our ward, then actually the next place really is Broadmoor. Right to people who have learning disability, who don't have the same kind of violence issues, etc. If we are saying to people, look, we're not going to bother giving you the same access to smoking cessation and the same opportunities to stop smoking as everybody else, then we're doing what everybody else is doing to our client group. We are basically marginalising them and saying that you're not the same as everyone else. For some reason, we don't feel that we can give you, the mechanisms and give you the informed choice. So we wanted to equalise access to smoking cessation services. We wanted to try and improve health and well-being. And, of course, we wanted to achieve the sequin targets because that's where the money is. The highfalutin aims, the ones that were perhaps a bit more unrealistic, we were hoping that the patients might be more satisfied. Although I have to be honest with you, I was thinking, my worry actually was that there might be more violence, there might well be a riot. We wanted to try and reduce admissions and transfers to the local general hospital. And also we were hoping that we might somehow be able to improve the skills of staff, because a lot of the work that realised a lot of the work that would be needed to be done would be using motivation interviewing approach. And also, eventually, of course, we want to try and reduce the physical health burden in this population of people. The kind of change, the drivers to this, there's, as you can see, trust-free smoke, the trust smoke-free strategy, it's been around for a long, long time. People have been talking about it a lot, nothing had been done. It literally was something that was being paid lip service to. However, a policy was developed in June 2012, and Mary persuaded the trust that our CAG could be the pilot place for this to start. I've mentioned some of the moral and kind of ethical reasons that people say as to why you shouldn't bring in a smoking ban. But what I decided and I think what a number of us decided is that essentially, when you try and unpick, if you are ambivalent and you try and unpick your reasons for why you think it might not be a good idea to bring in a ban, well, for me, I realised that I was actually stepping into the territory of therapeutic nihilism. Somehow or other, I was saying that my patients who, for those people thinking that all they've got is a cigarette, then essentially what you're saying is that the environment that you provide for them in the inpatient setting is so impoverished that actually only a cigarette is going to make them feel better. Now, for me, that means that we've got to provide them something a lot more than the equivalent of a cigarette. There was some evidence that actually reducing smoking might actually help to reduce violent incidents rather than increase them. And I'll say a bit more about that. And as I've mentioned, the money. And that's the thing that actually helped get the managers on board in the end, I think, when they realised that if they did this, it was going to help them, it was helping to fulfil our sequence targets. Mary conducted the 30th of March 2013 was the date that we went smoke-free. And prior to that, and I have to say, this is going on for about a year or so beforehand, Mary did an audit, and what we found was that the staff, 11% smoked, which is a lot fewer than I expected. And certainly when I started psychiatry 20 years ago, you know, it was the staff and the patients were going out hand in hand and having a fag outside. About 30% of staff have completed smoking cessation training already. We have level 1 and level 2. About 58% were already fairly regularly assessing the patient's smoking status. And very importantly, we found that about 90 minutes per shift was spent facilitating smoking. What a waste of time. We have got so much to do. You know, just getting people out and getting them ready to go and smoke and everything. At 90 minutes, that's a lot of notes that could be written, that's a lot of audits that could be done, etc. There's a lot of engaging of patients that could be done in a more healthy way. In terms of the wards, when you looked around the wards, you realised that all the wards were actually advertising smoking. It wasn't just that people would walk into the ward and when you want to smoke, smoke at this time. If you want to smoke, smoke over here. We realised that actually we were encouraging people to smoke rather than discouraging them to do so. So that just gives a list of some of the different types of, because all the wards are different, and there had to be local solutions for different wards. 8 of the wards, this is mainly the forensic ones, actually had designated smoking breaks between 6 and 13 per day. My ward, being the intensive care unit, was one that means that people can't go off the ward. You know, they have to progress from there. We have 2 gardens, but it meant that basically, up until we started to realise what we were doing, people had a smoking break every hour of the day, except for sleeping time. So there were about 14 smoking breaks a day. One of the things that made the difference, now when I first heard about this a couple of years ago, I thought it was some kind of urban myth. Did you hear? Broadmoor went smoke-free. No, they did not. It's like this. Oh, no, I don't believe it. I didn't believe it at first, but then I spoke with Alan Coe, and it was true. They'd gone smoke-free, and guess what? It worked. So we all actually, it was more than 2 or 3 years ago, and we all said, oh well, that's because it's a prison hospital, and they can just lock everyone up, and people have to do what they say, or else they'll, you know, and that's why. They've got some magic kind of, you know, guy who just insists, or else you're going to stay there forever. We found that, however, that when people came from Broadmoor to us, they don't come that often, but when they come, they step down. Quite a lot of them wanted to give up. They wanted to stay smoke-free. When we looked again, we found that only 20% of the learning disability patients smoked, compared with 78% of the forensic patients. And very, very unfortunately, 58% of patients who had previously quit smoking, they come into hospital and started up again. 70% of the staff actually wanted to ban smoking, contrary to what we thought might be the case. 62% of the non-smoking patients wanted to ban smoking, and about 22% of the smokers wanted to ban smoking. So even some of the smokers wanted to ban smoking.